Okay.
Yeah.
All right. I think we're going to get going. So thanks everyone for being here. We're going to talk a little bit about hormone replacement therapy today. If you have any questions throughout the presentation, please feel free to interrupt. Alina's going to be in the back and she's going to be taking questions for people online, for everyone online. Thanks for being here. Thanks for joining us. And let's get to it. So just a little bit about me. I'm a licensed naturopathic physician and a self-proclaimed bougie hippie, right? So I'm looking for effective therapies that support the body's natural processes, but I want things that work, right? I'm not going to cover my face in dirt and think that that's going to make wrinkles go away. I've been practicing for about 10 years, and in the last decade, I've definitely practiced. I've tried all sorts of things, and I'm excited about hormones because it's one of the therapies I find incredibly supportive and helpful and game-changing for people, which is huge. Strong convictions loosely held. It's one of my favorite sort of ideas that really we are believing in what we do, and I hold on to it strongly. But if I get new information, if I get new data, if I learn something new, I'm going to shift. I'm going to move. You got to stick with what you know and what really makes sense. And then I also think of how I'd want to be treated as a middle-aged woman going to a doc. I feel bad if they said it's your age. I might lose my mind. So let's figure out how we can support each other in this process. Tell them what you're going to tell them. So today we're going to talk about different types of hormones. We're going to talk about how they affect the body. We're going to talk about how they change over time and then what different deficiencies might look like. I want to dispel some myths about hormone replacement therapy. I think that's really important. And then I want to talk differences about bioidentical and synthetic preparations. That's important to cover. There are different ways that we can get hormones in our body, and I want to give pros and cons of each. And then we'll follow up with what we're doing here at Bridgeport Laser and Wellness. All right, so let's meet our hormones. This is my girl estrogen. She is sassy, she is strong, she is powerful, and she does a lot for us. Well, she also needs to be kept in check. If she's running rogue, she's a little bit of a bitch. And so we just want to keep her as kind and regulated as possible. We all need a little bit of that, though. I'm okay with it. Estrogen is really important in stimulating collagen and bones. When we think about collagen, the other thing we think about here at Bridgeport is we think about our face and skin laxity, whether it's on our body, on our décolleté, on our neck, or on our face. That's going to be something to consider as we're getting older and estrogen's going down. We just see more crepey skin. Serotonergic activity. So serotonin is the neurotransmitter that makes us feel connected. It makes us feel happy and joy, and estrogen stimulates activity, which is great. So that's how it can help with our mood and our function, our cognitive function, our memory. Moistens and lubricates tissues. Yes, we're always thinking about the vagina, but also just our face and again, our neck and our décolleté. So you can be applying as many creams and serums as you want to, but without estrogen, it's not really going to absorb and going to stick. And then we do know that estrogen supports metabolic health and can reduce risk of cardiovascular disease later on in life. So symptoms of low estrogen. This is when we see the hot flashes and the night sweats and the difficulty with temperature regulation. We feel terrible. We're depressed. We've got mood swings. We see the puppy commercial and we start to cry. We can't remember anything. I can't tell you how many women are like, I'm at work and I just like miss names of things that I know very easily. The vaginal dryness, pain with intercourse, that's definitely an estrogen issue. And osteoporosis is very interesting. If you think about bones, we've got the structure of the minerals that make the, like that absorb calcium and everything to make the hard part, but bones are actually very bendy as well. So estrogen helps with the elastic part and the collagen part within our bones. We want our bones to be strong and flexible. And so estrogen actually does both of those things. It's osteoblastic, and then it's also helping with collagen. So we like that. And again, that thin, crepey, sagging skin. Here at Bridgeport, we have a lot of people who are like, I just need some filler. And they're lifting their face up like that. Sometimes that's a little bit more of a skin laxity issue than just getting a little filler. But we have tools for that too. So then this is my girl progesterone. She's like meditating, she's doing yoga, she's cool, she's chill. This is very GABAergic. And so GABA is our neurotransmitter that likes things like Ativan and Xanax, those things that bring us peace and are very calming. So we do a lot of progesterone at night because it can help with sleep So women who are having a lot of hot flashes at night, a little bit of progesterone before you go to sleep is wonderful. Progesterone relaxes muscles and relieves anxiety. Tension headaches or migraines can also be a symptom of low progesterone. So a lot of times we'll do topical progesterone with magnesium to apply to your neck and your back, and that can help with tension headaches and migraines. So these are my symptoms of low progesterone. Little puppy has a headache and the other one's really scared. And so we're just like agitated, just kind of on edge, not sleeping well, anxious. And yeah, we can feel those things. So then we got testosterone. So yes, women, ladies, testosterone is huge for us. In menstruating years, we have like this much estrogen and we have this much testosterone. We have quite a bit more testosterone than estrogen all the time. Now, guys have testosterone like through the roof, right? They've got quite a bit more, but testosterone is important for us women too. Testosterone stimulates protein synthesis. So that's our muscles, but it's also our collagen and our face, our hair, and our nails. So if we're getting dry, brittle nails, or if our hair is getting a little thinner and falling out, that can be a sign of testosterone deficiency, which a lot of us think testosterone excess. It can be that too, but it can also be a testosterone deficiency. Testosterone helps regulate insulin. And so when I've got my ladies who are in their 40s or 50s and they're working out all the time and they can't lose weight, a lot of times that's because the insulin signaling is just not on par the way it should be. And so giving testosterone can be helpful for that. All right, prefrontal cortex. So that's the executive function in the first part of our brain, right? So that's when we're trying to make sense of the world around us and we're thinking about things. This is not like a knee-jerk reaction. And when we're thinking about things, we can regulate our behavior when we're in social situations. Low testosterone usually results in a lower ability to regulate your mood and your emotions when you're in social situations. So think of like your kiddos when they're young boys and they're just like, they don't care, but then puberty hits and they're like too cool for school, right? Because that testosterone comes in and helps with that prefrontal cortex activity. I thought that was new. That was new for me. That was a good nugget. So yes, testosterone, guys are welcome here too. So this is my handsome fella playing with his wood, and that is very important for testosterone. And then we've got warrior, right? This is our war hormone. This is our resiliency hormone. This is our ability to tackle the wild day-to-day that we are all enduring. Low testosterone, so libido for sure. Men and women, low libido is an issue. Belly fat, especially around the middle, we'll see, again, memory loss. Sugar cravings, because that usually a result of insulin resistance. Insulin gets the sugar in the cells. If the cells don't have sugar, they're still telling the brain to eat more sugar. Come on in. Hi, you're fine. Come on in. So we're going through our hormones right now. And we're just talking about testosterone. We're giving them a little personality so we kind of understand a little bit about it. Welcome. But yeah, so since testosterone regulates insulin, if we're not getting glucose into the cells, but it's just in the river and the bloodstream, the cells signal to the brain, hey, you're hungry, you need sugar, you need sweets, you need energy. So we may have a lot of glucose in the blood, it's just not readily available. And so we want to eat snacks all the time, and specifically the sweet, salty ones. Impatience, depression, again, that's the resiliency piece, and migraines also can be triggered. Migraines have a lot of different triggers, but all right, so how do they change over time? Guys, you got it easy. It's a gradual decline. It can start at 30, 40, 50, 60. It really depends. I've got some guys in their 20s that I'm working with testosterone replacement, and then I've got some guys in their 60s we test and they're doing great. So different reasons why it could be happening, but that's a pretty simple, straightforward decline for the guys. And then ladies, it's complicated, right? We just got to make it a little harder for everyone. So this chart is one of my favorites. The top box on this chart are 6 cycles of estrogen, progesterone, the hormones we talked about, and then LH and FSH, the signals from the brain to the ovaries. So over 6 cycles, we have the same circadian rhythm that lasts about 28 days, and that's just healthy menstrual 6-month, half a year. The next one is perimenopause. So this is the time where we're not quite done ovulating, we're not quite done bleeding, but it's kind of a little chaotic purgatory time. So as you can see, all the hormones are kind of going all different directions. It's a little bit trickier to work with in this phase, but we can do a lot of really good things to help ladies out. And then finally, we have post-menopause. So menopause is one of the only diagnoses that we can get post hoc. We don't get diagnosed with menopause until we're 12 months without a bleed, right? So that whole like year where we're like, am I done yet or not? Or what's going on? We're getting to this phase. And at this phase, estrogen's done, FSH is high. We use those two markers when we're repleting hormones to kind of see how happy the body is with it. But, you know, women will ask, do I have to be on this forever? You're not going to make estrogen again, so you don't have to. But if you want the estrogen, you're going to have to keep repleting that. So for women, why would you want to have it or not to have it? It depends on how your symptoms are. So there are some women that slide into menopause and they're just like, no big deal. No hot flashes, no pain, no vaginal dryness. Their skin still looks nice and plump and fluffy, and they don't have any issues. There's some women that have a lot of symptoms, and so they can get a lot of relief and have a better quality of life when they're repleting estrogen. So it's an individualized decision. We all get to choose how we want to do it. Yeah. My experience, progesterone tanks first in us ladies. That's why they would call over 35. I think they used to call it a geriatric pregnancy. Now they're calling it high risk. But yeah, the terminology is bananas, right? But if you think progesterone, progestation. So progesterone is what's running wildly through our bodies when we're pregnant. It allows us to stretch, it allows the tissues to move. Most women don't get migraines when they're pregnant. Some women have the opposite. It's wild, but that starts to decline around 35. And then we'll see testosterone usually takes off. It starts a slow decline in our 40s. Estrogen is that sharp decline at 50 if we have, you know, the natural menopause. But again, the language, premature ovarian failure is one of the diagnoses if you're in menopause before 50. And also if you have surgery. If you have an oophorectomy, then we can see some surgically induced menopause as well. All right, don't the hormones cause cancer? Because that's what everyone likes to say. So back in the 1900s, they ran a study called the Women's Health Initiative. They started it in the early 90s and they ran it for about 10 years. It was almost 200,000 women. It was one of the biggest studies we've ever done for looking at women's health. And they wanted to test, do hormones help prevent cardiovascular disease later on in life? So they took women aged 50 to 79, gave them all a couple of different things to see what happens. This one reporter was talking to one of the primary investigators. How's it going? The primary investigator said, we're seeing a lot of cancer. Well, guess who went and wrote an article in Newsweek? So this article came out 2002 that hormones cause cancer. The final results of this study started getting published in 2004. So this was a little early, a little premature, and also not really factual. But what happens is that something scary in medicine sticks, like, you know, sticks well, and it's hard to change dogma. So there's still a lot of practitioners that are not prescribing hormones because they think it causes cancer, but we can really look at the details of this data. So there was a placebo arm, and then there were two different arms that they were testing different hormones. So when they give Premarin, that is an oral conjugated equine estrogen. It is a oral synthetic estrogen, and they would give that to women who did not have a uterus. Because if you have a uterus, you always want to give progestin or progesterone with your estrogen. So women who are status post hysterectomy, they got Premarin. That arm, we actually found a reduced risk of breast cancer, especially compared to women at the placebo group who were overweight or obese. We saw fewer fractures and we saw less incidence of colon cancer. We did see an increased risk of stroke, and I'll hit that on the next slide. We'll just put a pause on that for now. But then there was the other arm. So this was Prem-Pro. So this was Premarin, oral conjugated equine estrogen, and Provera, which is a progestin. It is a synthetic progesterone called medroxyprogesterone acetate, or MPA. This arm, we also saw reduced risk of fractures and colon cancer, but initially they published it an increased risk of breast cancer and blood clots. About 10 years later, they start to revise the data. They have newer technologies to look at the statistics, and they're saying, actually, there's insufficient evidence that there was an increased risk of breast cancer. So now they're starting to say maybe there wasn't as much of an increased risk of cancer. But what we still know to date is that the mortality rate of the cancer was not any higher. So if you look at deaths of the placebo group and the group that was in Primpro, there was not an increased risk of death with the women that were in the treatment arm. So then we start to think, okay, well, what could have happened? Well, when you were in the study, you were getting mammograms every year. How many of us actually get them every year? Sometimes it's like, oh, it's every 14 months. It was 18 months. We miss. We sign up, but then it gets booked out. We can't get in to see somebody. So there's some theory that perhaps we had a lot of false negatives where we were finding cancers and it was getting diagnosed as cancer, but then when they did the biopsy, it really wasn't. Maybe there was just an increased risk of finding it. So that's still kind of to be determined. But let's talk about the stroke. So one thing that was really important with this study is, again, they took anyone from age 50 to age 79. When you're 50 years old and you're fresh out of menopause and you're fresh out of hormones, you're going to be very different than if you're 79 and you've had 29 years without hormones. So we found that there is a decreased risk of cardiovascular disease between 50 and 59 if they started hormones within 10 years after being in menopause. We did see the increased risk in women over 60. So because of this, from 20 years ago, this is why we still say no hormones after 60. And so you stop. If you start in 50, you stop when you're 60. And we're not going to start you if you're greater than 10 years after your menopause. Even if it was like a premature ovarian failure and you were 35 when you stopped menstruating, we're not going to give you hormones after 45. We need to really look at what that means, right? So Premarin, it's an oral conjugated equine estrogen. Most of us know birth control increases our risk of clots, right? Women who are on birth control, don't smoke. When you're on a plane, be careful. We know oral estrogen affects our liver enzymes and how they make clotting factors. We already knew that there was an increased risk of clots. You give someone who's 80, who has a higher risk of cardiovascular disease already, you give them estrogen. Hey, well, there you go. That's a little bit different. Transdermal estradiol is one of my favorite ways, and we'll get into the different ways, but that's going to be metabolized very differently in the body. So we have to look at the different mechanisms there. There's also a theory that as we get older, our vessels become more rigid, especially in the absence of estrogen, right? So collagen also goes around the tubes. And so we don't have collagen. We don't have as much flexibility of our vessels. If you then give someone who's had hardened vessels for 20 years, estrogen softens them. Could that mobilize a thrombus that wouldn't have already been mobilized? So that's another theory as to why this might be happening. All right, so the important part here is we also know estrogen can increase our risk of endometrial cancer if we don't give it with progesterone. So a lot of conventional docs will say, okay, you've had a hysterectomy, we'll give you estrogen, you don't need progesterone. I personally like them both together. They are the yin and yang to each other, and they just pair really well and they play nice together. But yes, we all agree, estrogen, endometrial cancer, that is a thing. But one of my favorite sayings, words mean things, right? The delivery method matters. The type of estrogen matters. The type of progestin or progesterone matters. And so we need to think about those things as well. And your risk factors. If you've got a really long family history of cardiovascular disease, we may not want to do a lot of estrogen, but we can still do testosterone. We can still do some other things. This doesn't always work well in the conventional medical model because it's very individualized. Everyone's going to be treated a little bit differently. So it's hard to do that in 15 minutes. So there's a big difference between compounding pharmacy and commercial pharmacies. Our compounding pharmacies, we send in prescriptions, we can make unique doses, we can eliminate other factors that we don't want, we can combine things, we can make it really specific for you. We also have the commercial pharmacies, Rite Aid, Walgreens. We finally have bioidentical preparations at the conventional pharmacies, which we like. Insurance will cover that. FDA regulated products versus the compounding pharmacies that I like here in Oregon. They're following FDA regulations, but the FDA doesn't test each product that leaves their office. So it's just a little bit different there. And then again, the synthetic versus the bioidentical. So our synthetic, oral conjugated equine estrogen, birth control, the NuvaRing, IUD that has hormones in it, Mirena, Skylar, those are progestins. In the literature, if you start researching, they're going to call it a progesterone or a progestogen. That gets really confusing because they're calling medroxyprogesterone acetate progesterone. but it's not, it's progestin. So sometimes we have to dig a little bit through the research. The bioidenticals are usually named exactly what they are. Estradiol, it's a type of estrogen. Estriol is a type of estrogen. Oral micronized progesterone, those are my favorites. And then the pellets and the injectables are usually bioidentical as well. That means the chemical structure of what we're giving you looks exactly like what your body makes. So that's a little bit different. The synthetic hormones, it's a similar chemical structure that binds to some receptors, but not all. So it may bind to receptors in the uterus, but it's not going to bind to brain receptors. So you may not get the cognitive benefits of a synthetic estrogen, but you could get other benefits from like cramping if you have endometriosis or something. Any questions? How we doing? Anyone online? We're okay? Just gonna keep cruising. Okay. Different preparations, topical creams and gels. These are good. It's good to dip your toe in if people are a little nervous about jumping right in. It's a daily application. You're going to have a peak and a valley and a peak and a valley every day. There could be something good about that. You can have a washout period. But when I run labs on people who've been doing it and then they don't apply it the day of the labs, they're a little bit lower than where they once were. So if you miss doses, then you have lower hormones, and that can be a little bit problematic. I like that we're not relying on the GI tract because that just means the bioavailability might be a little bit easier. A lot of these are available at compounding pharmacy. Sometimes you can get them already commercially available as well. Estriol E3 creams for vaginal health is a common cream that will be available at like Rite Aid, Walgreens. Patches are also good. I like these because it's the steady state, right? So you stick the little sticker to you, 3-4 days, you get steady state of estrogen, and then you place another one on. If you're sensitive to adhesives, that can be a little bit problematic. And remembering to do things every 3 days is kind of tricky. I've tried my own like injections and other things. I'm like, shit, what day am I on? I don't remember. So we're busy women. We've got a lot to do. And maybe remembering to change the patch is a little bit tricky, but it's better than a daily thing for a lot of us. Troches or sublingual lozenges. So these are like little waxy things you can cut into quarters. Again, bioavailability is going to depend on a sublingual absorption, but we can mix a couple of things together at a compounding pharmacy. You can have your testosterone and your estrogen together, and some people really like that. But it's daily. It's going to be a daily dose as well.
Is that like a pill or is it like a wax block?
It's like a wax block, and you cut it and then it slowly melts. So you put it under your tongue, and as it's under your tongue, it's like melting. And we've got 2 really large veins right under our tongue, and it's just going straight into the blood. So you swallow a little bit of it, so you have some PO or oral, but most of it just goes straight into the blood, unadulterated, kind of like the patch. So we like that we don't have to rely on like gut metabolism and all that. Yeah, yeah. Capsules, also really easy to take. We're all used to taking some pills. Really the only bioidentical capsule I like for hormone replacement is progesterone. There's estradiol capsules. I kind of can't believe we're still giving that to people, but we are. I see it all the time. You know, oral estrogen just takes a different turn on our liver, and it really can do things that we don't necessarily want it to do. And then we've got our injectables. So I would say 80% of the guys I work with, they're injecting testosterone every 3 to 4 days. Must be nice to be a guy sometimes. They actually can remember every 3 to 4 days because that's the only thing they have to remember. Sorry, guys, if there's anyone here, I have a bias. But it is relatively convenient. It's a little tricky when you're traveling with needles and syringes, but if you have a prescription, it's not too bad. And then it's kind of like the patch where you have this like slow pharmacokinetic pathway, right? Like just a little bit and then it gradually tapers off. And then we get to the pellets, and the pellets are kind of my favorite. It is a minor surgery procedure. We cut a tiny little incision into the skin, and we use what's called a trocar, which is just a little tube that we poke in. We drop these little pellets. I mean, this is what a woman's dose usually looks like. This is a little bit of testosterone and a little bit of estrogen. We slide those in. We put some steri strips on. It's a 15-minute procedure. You're out and on your way. There might be a little bit of soreness, a little bit of bruising, but so far people aren't having a lot of issues with it. I like it because we can also set it and then forget it. You get 3, 4, 5 months of pellets now where you're having a steady release of hormone. And the release of hormone depends on your metabolism. So when you're working hard, you have access to the hormones, you can use them more, which is how our body does it anyways, right? So we do like to test labs just to see how it's going. And because they're bioidentical, they will show up on labs. If you're doing an oral, conjugated equine estrogen and we test estradiol, it's going to be 0 because that's not the same as the bioidentical estrogen. So you can't really run labs to test the synthetic hormones either, which I don't like that too much. So here at Bridgeport, the way we're doing it is you get to consult with the provider. For right now, that's me, but there may be somebody else coming around. We want to look at your history. We want to look at your symptoms. We want to look at your interests. We do run labs. I'm a big advocate of running labs. As I said before, we can do estrogen and FSH. FSH is going to tell me how your brain feels about your estrogen levels. So yeah, it may be coming up a little bit, but if FSH is still like menopausal range, we can increase that a little bit more and bring the FSH down, which I like. If you go to a doc and they say there's no reason to test labs, we don't do it, go find another doc, because we'll run tests on women that want to procreate. We'll run tests on women for fertility all day, every day, but not in menopause, not in perimenopause, not even premenopausal if you're just having symptoms. So labs are helpful. We take them with a grain of salt. We need to know where in your cycle we're testing, but they are helpful and we like to do those here. So after we run the labs, we'll meet with you. We'll talk about what's low, what's not, what might we want to replete, what are the options, and what works for you and your pocketbook and your lifestyle. And we come up with a plan. And I've done all different things. Some women are like, I don't know about pellets, and we give them a cream, and then they're like, okay, and then they jump in. And some women are just like, okay, I'm just doing it, right? Like I need an option. So it's always up to you, right? You're in control. I am here to be of service, right? This is a service profession. And so if your doctors are not treating you like that, find a new one or add somebody else into the mix, right? So here it's going to be $150 for the consultation. For labs, we can bill your insurance if you've got insurance coverage, but we also have a contracted cash rate with Quest where it's $180 just flat. And then for female, the pellets are going to be $550. For males, the pellets are going to be $725 to $825. They take like 8 times as many. We're usually putting 8 pellets in the guys where we just saw like 1.5 for the ladies. So it's just a little bit more of an invasive and timely procedure.
Dr. Dunn, is there a better time to get your lab done?
Yeah.
If you're still menstruating, but you're pre or perimenopause, would you suggest having your lab done 2 weeks before the first day of your cycle, during your cycle? Where would you feel like you get the best lab results?
So if you're menstruating and having regular cycles, I usually start on day 21. Day 21 is going to be halfway between ovulation and menstruation, and that's when your progesterone is going to be at its highest. If you're still menstruating, we want to test progesterone on day 21 because I want to know where she should be and where she actually is to know if we need to give you progesterone. Most of the women that I work with that are menstruating, they're on either progesterone and or testosterone, but we don't usually give a lot of estrogen. Because as you saw in that chart, in perimenopause, when we don't know how our cycles are, estrogen's going like this. And if we have a surge of estrogen when we're giving ourselves estrogen, we are going to be a hot mess. We're going to be crying at everything, and it's not going to work out well. So for menstruating, I usually do day 21 or as close to it as we can. If we're irregular and we don't know, that's fine. I at least know that when we're testing it. And then if you call me the next day, like, oh, I had a bleed the next day. Okay, we can use that information. It's another reason why I like FSH, because FSH is going to be running differently at different parts of the cycles as well. And progesterone will tell us if we ovulated. So sometimes we can look at the labs and tell you a little bit of your status, like, be ready for a bleed. It looks like you might have just ovulated. And so something may be coming up in a month or so. If you're in menopause and it's been a year since your last cycle, come in anytime. Doesn't matter. Yeah. So just a little bit, again, my soapbox here is we have options, ladies. We do not have to suffer. We don't have to grin and bear it. We have some options to help us feel better. Ask questions, ask your provider, push them, If they don't want to do it, like I said, get somebody else on your team who's more informed and ready and eager. Talk to your friends, see what your friends are up to. I think back, I think of my mom's generation. She went through menopause right around the turn of the century. Hormones were a big no-no. And so all these women were just grinning and bearing it, and they weren't sharing stories and they weren't talking about it. And now we're starting to see the evidence of women who went 20 years without any hormones, but they're still healthy and active. And it's kind of startling of what's going on. So I'm excited for us that we can kind of shift with that a little bit. And the other thing, hormones, they're very finicky, as you might have heard. High levels can look like low levels can look like high levels. So whatever you start, if it doesn't work initially, I encourage you to keep trying. You may be able to find a different combination of something that works for you. And there's no harm in that. Just keep trying something else. And that's the it. That's the it. That's it. That's all I got. Yay! Right now, let's get it. Yeah. Yeah. We'll get you on the books maybe before you go. Do you have? Yeah, we've got time. Yeah. Yeah.
I did have one question. about
Please.
The lab.
Yeah.
When, and this is for me personally, when I am ovulating,
Mhm.
life is great.
Ah.
And I've always been curious, like, I would love to get a lab done when I'm ovulating.
Yeah.
Because I just want to live
Like
there.
that. Great.
That's where I want to
Yeah.
the-
Yeah.
everything's good. And I
Yes.
just have like a 5-day window in
Yeah.
every single month where
Yeah.
it's like, my husband's cute, my kids.
Yes.
Like, work is.
Yeah.
fine, like, not all
Yeah.
hours.
Yeah.
So, like, whatever that, like, how can we mirror
Do that other,
or-
yeah.
and try to make that more of a permanent.
Yep.
Stretch.
Yep. Yep. So where I might start is doing a lot on day 21, and then I can send you with a requisition, and you can take that to Quest anytime on those 5 days. Because even if we're not here to do a draw, you could take one closer to your house or to a lab that's close to your house, and we could capture a few different things.
Okay.
Just based on what you said, my guess is you might be a little bit either estrogen deficient or your estrogen metabolism is off, because estrogen soars right around ovulation.
Okay.
That surge in estrogen is what forces the ovary to release the egg. And so when I hear women feel great right around ovulation, it's usually an estrogen piece. But sometimes then we feel like shit later because we've got all this estrogen but not enough progesterone. So I would want to capture both.
Okay.
Yeah, yeah. That's it. No big deal.
Good job.
Cool. Thanks. Anything online? We're all good? All right.
Cool.
Cool.
That was good.
Well,
You got to be on that.
yeah.